Now, we are all aware that neonatal mortality continues to be a major issue for us to save the babies. And many programs have rolled out and they have proved to be effective, but still we have a very, very slow reduction in the neonatal mortality rate over the last decade. And as we all know, birth asphyxia contributes the major portion of this neonatal mortality. So we are contributing a major bulk to it. And as a result of this, as we understood through our first birth trial that training the birth attendants is definitely very effective, but the programs needs to be very simple, so has to be practiced by the peripheral health worker. So this helping breathing baby program, training program, which was developed by AAP, was an offshoot of the first breath or the NIP program, which, as we all know, is a very simple program which involves very beautiful mannequins, fascinating mannequins, which are simulators, which can cry for us. They can show us how the babies breathe, whether they're crying or not. So that a sort of a technology was available in this program with simple modules, which had very, very, very simple steps, scenarios to be trained to the health workers, which could be practiced by all at the community level. So it involved the flowcharts like this, which were very simple. And the whole concept was based on making the babies breathe in the first golden minute, which has a very good, the component of this particular program. So this program was first evaluated, pilot tested in many of the countries, and our site was one of it. And as a result of this, the global leaders came together and formed the alliance, and many countries rolled out this program. More than 25 countries rolled out this program in 2010. But the question remained whether only training with HBB or the other resuscitative programs is going to be effective in saving the babies' lives was a big question mark. And for that, NICHT was called into place to evaluate this particular program, whether helping babies breathing is really saving the lives. And so we started with this particular program with our site, Kenya and Nagpur. And we looked at this as a pre-post evaluation study at the facilities, facility-based training programs implemented within our clusters in the global network at these particular 3 sites. The whole objective was to evaluate the impact of implementation of not just the HBB training, but also this was an integrated package of training with ANC and HBB, and also providing the equipments to the facilities, and also training the birth attendants. So it was a whole package of ENC and HBB together, and we were looking at outcome has decrease in the perinatal mortality. And of course, the secondary objectives being how much knowledge was improved, the skills of the birth attendants improved in these trained facilities. We again went back to the MNH registry for this, and we looked at the facilities based with the MNH registries, and we contributed around 44% of the registry births in the whole program, and covering around 33 facilities with 8,000 deliveries. Now, these were our training facilities. And the whole concept, the hypothesis being reduction in the perinatal mortality among all the registry births by training the birth attendants at these facilities, which accounted for 44% of the registry births. So we had both the sectors, the private hospitals and the public hospitals. We trained around 25 of the public sector facilities, all at all levels, at the PHC level, CHCs, taluka hospitals, and the district hospitals, covering around 32.2% of the deliveries, accounting for 6,000 deliveries in these areas. And of course, the private sectors, we had the tertiary care hospitals, district hospital, and the clinics, the smaller clinics. These facilities, we took it as the facilities which had 24 hours services and also deliveries of more than 300 per month. The intervention was very simple. The first intervention was to select the master trainers because training was a major component in this program, and the birth attendants, and HBB training as a second component. And the third most important component was after the training, there was a quality improvement monitoring system, which was very much effective and which was very, very important in this program. So training model was again the trainer model, where master trainers were trained by the AAP HBB staff. They came over here and trained us in the HBB program, and these in turn trained the facility coordinators at each of the facilities. They were trained at level 2, and these facility coordinators, along with the master trainers and the central team members, trained all the birth attendants in these facilities. And these also acted as the QI managers for us, who monitored the deliveries conducted in these facilities. The whole training involved all the people responsible for the care of the newborn, like the physicians, the nurses, ANMs, they were the master trainers. So the involvement was very good, and the peer teaching level was very, very high. And we had mixed groups at each training session, and we used the pair teaching and skills exchange practice in training. Most important was post-training. They were evaluated for the retention of skills, and if the skills were inadequate, they were trained after 6 months as a refresher training course. So there was always refresher training and recertification of these birth attendants at the facilities. That's very much unique to this particular program. And master trainers were responsible for the initial training and also for the ongoing monitoring and retraining of these birth attendants. And of course, master trainers worked in diets whenever possible, and the ratio of master trainer to trainee was 1:6, as recommended. So this is the group of our master trainers. These are our master trainers involved in the program. The strategies which were used for the training was very much unique in the sense that every training there was presence of a central team member, and there was a lot of coordination between the central team, the master trainer, and the facility coordinator. And of course, there was monitoring all through and through, and we assured the quality by frequent visits by the QI managers. So initially, we trained, we were expecting 739, but as was in the previous trial of first birth, we trained increased number, because we didn't want to miss any birth attendant taking care of the newborn. And so we could achieve a very high percentage of training in all the sectors, public sector and the private sector. And for the refresher training, we identified the active birth attendants, and so the number reduced, but we could train all the birth attendants in the identified facilities. So these are some pictures of the refresher training at the facilities. The focus was on identifying where the baby was crying, and the next step of stimulating, drying the baby, which is a very important component of this particular program. The QI strategies which were employed was the QI managers who were localized at the centers, at the facility level, used to visit the facilities and observe the deliveries conducted by the birth attendants every fortnightly. Apart from that, there was review of the perinatal deaths, there was debriefing of the resuscitation process, and most important was we established HBB Corners at each of these facilities, where the birth attendants used to practice every day before they entered into the labor room. This was very much unique to this program. They maintained a log of the practice. So this daily drill was a very, very important component of this whole program. And this was all recorded, and there was bi-weekly meetings and bi-weekly reporting to the central team of their resuscitation practices. So each component, each step of resuscitation, training, and the post-training event was captured in the data. So some observations which were done by the QI team was, with this process of QI monitoring, quality assurance, retraining, we could have a very good uptake and retention of the resuscitation skill, which is very much important for these programs. And they improved the resuscitation practices. And once there was somebody supervising them, delivering and resuscitating the baby live, their confidence level increased. And most important was they could resuscitate the baby in the golden minute, which was again captured by an app, Android app developed by our unit. And of course, the study has been published where they could correlate and say that most of the birth attendants resuscitated within the golden minute. This was the study population. We could capture 35,000 of the birth registries and also at all facilities totaling up to 70,000 births. And this pre-program was from October 11 to 2012, September, and post period was September 30 up to 30th of September 2013. And when we looked at the demographic and the clinical characteristics of the pre and the post data, they were almost similar in all the aspects relating to the registry deliveries, birth locations, except for these two parameters, which were the birth weight of the babies, which increased the post period, especially at our site, and also the cesarean section deliveries. And the mortalities, of course, when we looked at the perinatal mortalities, pre and the post, of course, it was not statistically significant, and also with the fresh stillbirths. And we also looked at the early neonatal death by day 7. So the pre and the post didn't make much of a difference. But when we were looking at the birth weight which increased, the low birth weight rate increased in the post period. So we did a post analysis as stratified for birth weight, and we could see that perinatal mortality rate definitely had a significant reduction in the low birth weight babies than in the term babies, especially at our site. So there were a lot of strengths in the study in the sense that we covered a very large sample size. I think this is first of its study which has involved a very large population at all levels, low income, semi-urban and rural areas. And we have used well-established methods to identify and train the birth attendants. And the most important component being the rigorous training of the birth attendants, not at one point of time, but throughout the period. And of course, the quality monitoring system, which was very well supported and which was very much supervised, which is definitely a very important strength in the study. So the whole speciality of this HBB program is it focused in skill acquisition during training and retention of the skills, especially by daily drill and refresher training, and of course by debriefings of the resuscitation and death audits, and of course the quality monitoring event. I would like to conclude in saying that, of course, this study did not show us a significant reduction. There are many factors responsible for that, but we did demonstrate that it's very much useful in low birth weight and high-risk newborns, and we understood the complexity of scaling up the evidence-based interventions developed in the developed countries to our low-income setting thing. But this statistics doesn't make any inference to me. My most important inference was we looked at the birth facilities and their birth NMR rates when we were going through the resuscitative debriefings. And I would definitely say that we did make a difference to the babies in the communities. And if we have saved half of what we have predicted here, I think that would make a very good impact, that we have made a very good impact in the communities. And I'm very proud to say that this HBB has been continued in these facilities, and we are saving babies. Of course, we have not made the statistical significance, but definitely this has improved the birth attendants' training and their confidence level in saving the babies. Thank you. This is our team.